Intracardiac echo imaging. Dr. David Callens is a professor of medicine at the University of Pennsylvania School of Medicine and a proctor for the AccuNav Catheter Peer Training Program. He will guide you through the intracardiac echocardiography imaging targets appropriate for arrhythmia ablation procedures.
There's been a revolution in the way that we choose ablation targets as ablation procedures have become more and more complex. We used to view ablation as totally determined by electrical recordings, which, if you reflect on it, is a very non-anatomic way of looking at the heart. With AccuNav and ultrasound imaging, we can see the anatomy that is generating those electrical images and see things like catheter contact and really image ablation targets for the anatomy that they provide.
Dr. Callens will review catheter insertion technique, followed by the imaging targets for atrial flutter, atrial fibrillation, and ventricular tachycardia ablation. Catheter insertion.
The catheter should be advanced through the 11 French sheath with some care not to damage the ultrasound elements at the tip of the catheter. It's firmly placed with a minimal amount of pressure that it takes to get through the introducer sheath. The initial landmarks in doing this are the descending aorta, and then the liver, and then the heart itself. Once the catheter is advanced through the venous system and up into the IVC, right atrial junction, and the natural position is at an anterior view that shows the tricuspid annulus, right atrium, tricuspid valve, right ventricle. One thing that's very important in manipulating the catheter is very subtle movements in the clockwise and counterclockwise direction, kind of with the idea that you're directing a very large imaging plane from the tip of the catheter. So very subtle movements move it through space in a big direction.
Imaging for atrial flutter ablation. By manipulating the catheter in the right atrium, the following routine images can be visualized for atrial flutter ablation: eustachian ridge, crista terminalis, tricuspid valve isthmus, tricuspid valve, coronary sinus, superior vena cava, and right atrial junction.
From this tricuspid valve kind of home image, we're torquing the catheter counterclockwise to move its imaging plane more anteriorly. We see first the eustachian ridge, and then coming higher we see the pectinate muscles in the lateral right atrium and the crista terminalis.
To obtain images of the coronary sinus with the catheter in the right atrium, with the tricuspid valve in view, rotate the catheter slightly clockwise. The coronary sinus will come into view. Using a slight posterior flexion and with the catheter positioned in the mid-right atrium, rotate the catheter clockwise towards the posterior portion of the heart. Slightly advance the catheter toward the superior vena cava, allowing the junction between the superior vena cava and the right atrium to be visualized.
There are times when ultrasound imaging is favorable for imaging the catheter ablation procedures done for atrial flutter, particularly in the setting of anatomic abnormalities. And such topics as catheter contact of the ablation catheter on the right atrial surface can be documented by ultrasound examination.
Imaging for atrial fibrillation ablation. By manipulating the catheter in the right atrium, the following routine images that can be visualized for atrial fibrillation ablation include intraatrial septum, left atrium, left atrial appendage and mitral valve, left pulmonary veins, right pulmonary veins, transeptal puncture, ablation and mapping catheters. To visualize the intraatrial septum with the tricuspid valve home view displayed, Use a posterior tilt to the tip of the catheter and rotate clockwise. The intraatrial septum will come into view.
From this vasovalis viewpoint of the catheter, the entirety of the atrium can be examined ultrasonically by a circle of the catheter in an anterior to posterior direction. But just recognizing where the chambers sit in an anterior to posterior circle relative to each other makes the catheter manipulation much more easy to understand. So pulling back just slightly and continuing the clockwise sweep, the next most posterior image to the left ventricle is the left atrium. And this would be a view that would be familiar for transeptal puncture of the vasovalis.
The left atrial appendage is best visualized along with the mitral annulus. Position the catheter within the mid-right atrium and rotate the catheter clockwise past the aorta. With the mitral annulus in view, the left atrial appendage will be displayed between 3 and 6 o'clock.
In order to get from the generic left atrial view that is used for transeptal puncture and with the left atrial appendage, there's a little bit more posterior rotation. And that brings us to the view where the left inferior pulmonary vein is seen, here exiting at 6 o'clock from the image, marked very well and distinguished from the left atrial appendage by its color Doppler and pulse Doppler signal. In this image also, superior to the inferior vein is the left superior pulmonary vein. From the left inferior pulmonary vein, we're advancing the catheter slightly and clockwise rotating. Further posterior on our sweep are the right pulmonary veins, which can be obtained by, again, subtle posterior movement through the imaging plane.
In some cases, advancing the catheter slightly towards the superior vena cava will aid in the visualization of the right superior vein.
The optimal position of the imaging plane for transeptal puncture shows both the vasovalis on one side of the imaging plane and the left pulmonary veins on the other side. Monitoring the ultrasound image and seeing the needle push and exert pressure against the vasovalis and tent this membrane, demonstrating that it is an adequate place to puncture the septal membrane. And then confirm the presence in the left atrium on echo by flushing the catheter. We see air bubbles on echo in the left atrium, confirming that the catheter tip is indeed within the left atrium. So we're anticipating ablating the left inferior pulmonary vein next. And in this view, we have two left pulmonary veins, the inferior to the left of the screen by the Accuson A, and the superior to the right of the screen at 4 o'clock. A lasso catheter is seen perpendicular, and the individual poles of the lasso can be seen by their hyperdense echoes. We're ablating in the left inferior pulmonary vein. One of the problems inherent with ultrasound imaging is some frequency interference between the RF generator and the imaging, and this can be minimized by going down on the frequency with that change from 7.5 to 5.5 megahertz. For atrial fibrillation procedures, we use the echo to size the pulmonary veins. We also do pulse Doppler pre and post ablation to demonstrate the absence of damage to the vein ostium with ablation.
Imaging for ventricular tachycardia ablation. By manipulating the catheter into the right ventricle, the routine images that can be visualized for ventricular tachycardia ablation include right ventricle, left ventricle, mitral valve, visualization of mapping or ablation catheters.
We'll enter the right ventricle with the catheter in order to maximize image of the left ventricle. The way that this is done, starting from this image, is anterior flexion of the catheter, kind of with the image of bowing through the tricuspid valve, and positioning the catheter within the right ventricle. As soon as the valve is negotiated, the catheters again remain to a neutral position to keep from making a circle through the right ventricle. Fluoroscopy is also helpful in negotiating this, but it can be done entirely on echo guidance as well. And typically from this catheter location, there will be a long axis view of the left ventricle, and either by advancing the catheter farther to bring the catheter more towards the apex of the left ventricle, or farther back if the imaging target is the base of the left ventricle, the catheter in its contact with the left ventricle can be monitored during ventricular tachycardia ablation.
The mitral valve is routinely displayed while evaluating the left ventricle. In this view, the mitral valve leaflets, chordae tendineae, and the papillary muscles are well visualized. Different scan planes of the left ventricle can be obtained by rotating the catheter clockwise. Additionally, to obtain a short axis orientation of the left ventricle, turn the right-left steering knob clockwise. To visualize catheters positioned within the left ventricle, position the AccuNav catheter in the right ventricle using the previously described technique. Slightly rotate the catheter clockwise until the area of interest can be visualized. Additional adjustments to the position of the catheter may be necessary to visualize the apex or the base of the heart.
This concludes the intracardiac echocardiography imaging section. Additional sections that can be viewed are catheter inspection and preparation and ultrasound basics.